So from the physician side, it really will help us in the more precise and personalized care of the patient. Right now, when we as physicians are concerned about the inaccuracy of eGFR based on creatinine, we will send patients for a nuclear GFR scan. That scan is incredibly expensive. It requires radiation, requires often multiple blood draws, a specific camera, and can't really be done at the bedside. Somebody has to go to a radiology suite, can take 4 hours to get that scan done. Our technology replaces that in the sense that it can be done at the bedside, and a GFR will be available within 3 to 4 hours for the physician to be able to make the determination on the best care in terms of drug dosing, laboratory tests, response to therapies, both in a longitudinal sense with any change to medications, et cetera. People will also say, I think somewhat understandably, but a little bit naively, that a serum creatinine isn't so burdensome for the patient, when in fact the patient has to go to a laboratory. They have to register for the laboratory test. They have to wait for the phlebotomist to be able to draw the sample. That sample gets sent to a lab. Sometimes it's sent to an outside lab, and it may take 2 or 3 days for that value of creatinine and then the eGFR to return to the physician. So creatinine is really not a point of care test, especially in the outpatient setting. And the burden to the patient in terms of time, I would say, is almost equivalent given the fact that they have to go to a lab and wait for blood to be drawn. So now we have a much, much more accurate, precise measure that much, much more closely approximates true GFR. In fact, it's almost exactly the same, and it's at the point of care, which creatinine cannot fulfill that need, and nuclear medicine GFR, which is more expensive than our technology, cannot fill that need either.